Hello, everyone, and welcome back to another recording of the Neurotransmitters. I'm your host, Dr. Michael Kentris, and today I'm very fortunate to have two guests on, and we are going to be doing a case presentation. So first off, let me have our case presenter go ahead and introduce himself.
Hi, Michael. Pleasure to be on this podcast. I'm Divij. My name is Divij Sharma. I am one of the doctors who's right now working in Mumbai, India. I have tremendous experience of working in neurology and subspecialization of neurology over the last 2 years in India and in Australia as well. And I'm just very delighted to present one of the cases which I encountered in Australia and up for a very good case discussion.
Awesome. Thank you so much. And our discussant who has bravely stepped into the arena.
Well, hello everyone. I'm Carlos. I'm a physician from Peru. I love neurology, and in fact, I'm applying to neurology residency this year. Hopefully, I will make the cut. Happy to start this challenge.
Awesome. So Divij has some excellent cases for us, and he's going to be hitting us with one today. So go ahead and start us off.
Yeah, sure. Thanks, Michael. So the case presentation which I have, so it was a bit of a dramatic presentation, kind of a puzzle when we first encountered this case. So she's a 54-year-old lady with past history of migraine and visualitis, who presented to a hospital with confusional state for 2 days. See, she was first in another local hospital with complaints of percussive fatigue, tiredness, breathlessness, and mild joint pains for about 8-9 months, for which she was given steroids and GCR and then discharged. No other history was given. When she came to our hospital, she was brought when she started experiencing multiple episodes of anxiety, panic attacks, and psychosis. This was in addition to the confusional state that she was having for the last 2 days. Upon further questioning, it only stated that she has been experiencing visual hallucinations for the past 2 days. Family had also noticed mild cognitive decline, intermittent behavioral changes for the past 8 to 9 months. The family, as well, we got some information from the patient, gave history of pain in the lower extremities for the several patients for the past 1 year, including joint pains and also neurofatigue. For personal history and family history was unremarkable. Now, on the examination front, we did a mini mental status examination. It was less than 24/30, by virtue of the confusion that she was in already. Cardiovascular, respiratory, and gastrointestinal ultrasound examination was normal. Although respiratory examination had some mild palpitations and right lower side. Coming to the neurological physical examination, we had the whole upper extremity and lower extremity. And I note the positive findings here. Muscle bulk and tone was normal. Power was grade 4 upon 5, or for the MRC grading in both lower knees. The sensory examination was normal. Deep tendon jerks were normal, all reflexes were normal, and both flankers were flexed. The distributed examination, there was no rash, no neck stiffness, no back edema on front discrete. There was no such swelling of fingers or brittle nails. There was no mouth ulcers, no alopecia. This summarizes the history in the clinical examination. Now, Carlos, what do you think? Where does the whole symptomology localizes to?
Okay, so that's very interesting. So for me, the first thing I will do is try to define this pattern of presentation in time. So this looks like it was a few days, right?
Yes, the confusion falls for a few days, but the panic attacks, the anxiety attacks, and visual hallucinations were over the past 1 or 2 weeks.
1 or 2. So I will define this as a subacute presentation of a multi-symptom disease. So we have altered mental status, we have visual hallucinations, we have the panic attacks and anxiety. So if I think in my mind about possible causes, probably more metabolic or autoimmune diseases will come into my mind. I will not think so much in something vascular, for example. but mainly some metabolic or other or autoimmune encephalopathies.
But in terms of let's say if you were to popularize into pain, where would this symptom occurs? In the nervous system, would it be, are you looking at the brain? Is it something when your medulla, something in the cerebellum, somewhere in spinal cord, somewhere in nerves? Where do you think the source symptomology could be useful?
That's a very good question. Is she only confused, or she's also somnolent or lethargic?
Yes, so there's confusion and visual hallucination, anxiety, and panic attacks, which are the subjective course, as you mentioned. This was the background of having fatigue, lethargy, and joint pains for the last 9-10 months.
Okay. So, because I'm thinking fatigues and joint pains, that make me think, autoimmune. But regarding localization, she's having visual hallucinations and confusion and altered mental status. That can mean a widespread involvement of the cortex, perhaps, or more localized involvement of some part of the brainstem.
Yeah, perfect. So it does localize the cerebral cortex because it's more of an encephalopathy, right? Very significant behavioral changes, visual hallucinations, and all that. So let's ignore the multi-system fatigue and the joint pains part right now. And let's just focus on neurology. So that's rightly said. It does localize to cerebral cortex today. And so based on the history and examination findings, what all etiologies would you consider here? What an etiology, like causes, or maybe in a differential symptom, saying just based on the history and physical examinations.
Okay, so if we define this as an encephalopathy, then our differential probably will include something infectious, like herpes encephalopathies, or other viruses. Our differential will also include some other autoimmune causes, like autoimmune encephalitis. If we are thinking about metabolic causes, then we can think in hepatic encephalopathy, although I have not saw other signs of hepatic dysfunction in her. I don't think she has asterixis or something like that, or uremia, uremic encephalopathy. And let me think. Other causes of infection can also cause delirium, which can give you confusion and the symptomatology. That's what I will think for now.
Perfect. So great list of differentials there, Carlos. And I really agree with you that how you were not in favor of a vascular cause. Yes, it doesn't seem like something which is vascular, considering it's very significant as it requires. It has varied psychiatric symptoms, which is basically hallucinations when other than confusion is when in the background of some symptoms. So with all the differentials that you mentioned, infectious, systemic, autoimmune, metabolic causes like hepatic or endemic encephalopathy, how would you like to start the investigation plan? What all would you like to send and or techniques or imaging? How would you like to start the investigation?
So I will definitely start with some basic metabolic panel, see her glucose, the BUN. I will take out perhaps a CBC. Looking at the other differentials. Maybe I will ask for some autoimmune biomarkers, ANA. I haven't mentioned this, but other autoimmune diseases with systemic involvement can give you this. Lupus, for example, can give you this. if I'm thinking about systemic infection, perhaps I will also ask a UV analysis. I would like. Oh yeah, go ahead.
Yeah, go ahead. What was the last thing?
Yeah, I would like an MRI, but I'm not sure if I can ask it at this point. In Peru, is something we definitely wouldn't have access immediately.
So let's take any two components. Let's do biochemicals first, which you ordered, okay, and imaging modalities next. So let's first discuss about the biochemical, which you already ordered, and second is the imaging modality. So one thing you probably missed out. Would you like to do a CS? We would like to do a CSF here as well, right? It's compensated cube and we would like to know encephalitis, infections. So that's one thing also we would like. So this patient had all of it. She initially, now I'll read out tell you the findings which she had in presentation. So hemoglobin was 9.1, fairly low. Total leukocyte count on hemogram on pad was 8,800, which is within normal limits. A platelet count was about 90,000, slightly low. Blood urea was 37, which is within normal limits. Creatinine was 3, again, nice, the normal limit. Sodium was 133. Potassium was normal. Erythrocyte sedimentation rate was 100. CRP, C-reactive protein, was 90. Again, the bar is mobile here. The urine analysis, the urine culture was negative. Urine protein had +4 proteins. So the urine had 2 red blood cells. Otherwise, there were no pus cells, no crystals, no bacteria. And in terms of the workup for autoimmune serology, so the ANA titer was strongly positive. Anti-dsDNA was also positive. And the anti-RNP, which is the ribonucleoprotein, was also positive. C-ANCA, P-ANCAs were negative. The C3 levels, which is the complement levels, were 60, which was me. And the C4 levels were the low. The CSF panel was completely normal. The proteins and glucose were normal. The serum glucose was also normal. And CSF panel was negative for any bacteria and viruses as well. Okay, so for biofile and CSF culture was measurable, which was negative. One notable thing which you mentioned about the other, which if you are exploring autoimmune encephalitis, at this juncture, she was very early on in her admission and investigation phase. No autoimmune titer was sent off at this point, so we didn't do this investigation right. Now the other investigations, the biochemistry, you had the answer. Now, Carlos, just what imaging modalities, let's say you passed all of this, you have these results, and what imaging modalities would you like to volunteer?
Also, so just thinking in the differential now that we had some labs, I will think, so my possibility of something being infectious like herpes encephalitis is less now, just because the CBC is normal and the CSF does not show up a pattern of HSV with blood or low glucose. Considering metabolic causes, it seems like the basic metabolic panel is also normal. But we have found some elevated biomarkers regarding autoimmunity. So my suspicion of autoimmune disease, particularly considering other symptomatology, I know you don't want that, but it's higher. So if I want to see a lesion caused by autoimmune involvement, probably I will ask for a brain MRI.
So that's it. You summarize them well. Obviously, in the context of positive autoimmune markers and slightly high inflammatory markers, and also high creatinine, creatinine. They're thinking something along with multisystemic lines where autoimmune falls there. So the MRI brain was completely normal. We did it on 2 occasions actually. and my briefest the normal in both the occasions.
Oh, that's
So we actually started off with the CT scan. I was considering cute and we started off the CT scan was done, and so was the indications. And the MRI angiography was also, say, we are looking at a vascularity person, especially some subacute vasculitis, which stands in acute encephalopathy. We had that in the French's early, the French's as well, which was also more. So the MRI angiography was also.
oh, that's very interesting.
Yeah.
So you order also a CT besides the MRI?
Yes, we ordered a CT before for the MRI just to exclude any major vascular issues and something that we may anybody missed early on. So as a protocol, we did order the CT scan, which was normal, and then we did MRI in two patients with an MRI angiography, which was also. So let's say, and what are your thoughts here? Where are you, or where as a clinician, as an intern, where do you think you're stuck right now? And who's helping you see?
So I think it's kind of harder now. For my perspective, I will say clinical symptomatology comes always first. Of course, the MRI may be normal, but regarding the symptomatology, again, that is multisystemic, and just and the positive autoimmune biomarkers, I would still think in something autoimmune. My guess will be to consider something like steroids, just to see if the patient gets any better. I am a little worried about the creatinine. Maybe if I am thinking of that she's has an elevated creatinine due to an autoimmune presentation of the disease, or maybe she's having a pre-renal AKI. I will have to consider that and perhaps give some fluids, probably. But I think that I can start steroids because my suspicion for infection is low. So I don't think I will be hurting the patient, hopefully.
Well, I do agree with you, Carlos. Before starting steroids, you've got to be careful and judicial, right? What if you actually suppress an immune system and something else goes on overdrive, especially if you're dealing with an autoimmune tree and body plays out in several ways. So before we actually speak about in the past, about what management meant to go ahead, just want to summarize the case history here. So this patient's done with behaving symptoms, psychiatric symptoms, confusion, visual hallucination, attacks. We did a blood work. We did find no hematite, no platelets. We did find positive autoimmune markers. That is a BSDNA. She had an elevated creatinine, which was very elevated. And she also had a positive urine protein. Now, urine protein was in the range of a nephrotic range protein lid, which is more than 3.5 grams per kg. And you have all these case history with you right now. So before you actually decide to go ahead and use steroids or something else, do you think this patient will be referred to other specialties so he can stop seeing things and have about the PG where you have? What specialty would you like to embody? And you can seek up like this NPC.
Oh, that's a very good question. And yes, definitely, I will ask perhaps rheumatology to give me a hand. I don't know if I can ask infectious diseases to rule out infection in here, or they will be super mad if I do that. But if I can, yeah, I can. I will ask also.
So you talk about rheumatology infectious diseases, right? So,
Yes.
well, infectious diseases on right you are saying that urine analysis is normal. Blood work hasn't been elevated WBC. CSF is normal, the urine analysis is normal. She doesn't have a fever. She's not in sepsis. Her vitals is completely normal. So why it was, you know, I'm discussing. You're right, Carlos. It's something like an autoimmune etiology. And they're saying the same thing. And we would light up this year and probably different ecology hand or a green and white, you know.
Great. What does rheumatology says?
So rheumatology is come to you and you know they're really interested. I'm saying in the DNA is possible, but anti-DNA is possible. So the thinking along the thinking along the lines of lupus, HDD is very specific. But we presume they're concerned about the high proteins in the urine and very high creatinine. So who do you think they're going to go to next?
Yes, nephrology will be of a lot of help. Yes, definitely.
Yeah, excellent. Yeah, of course. So nephrology is a new right? And they're also very interested in the case, okay? Considering now we are dealing with very high creatinine, it's very high protein variants, which is very alarming. And they're actually aware of how lupus can cause very debilitating nephropathy. So yeah, they now they turn to you, the team, okay? You're the main team in handle the case. He's look after this and patient, and they want your advice on management. How would you propose with the management of this patient, considering now that you have a differential, you have a broad differential, you have a diagnosis, you have all the teams of the fleet. In view of these acute confusion and needed management, you also involve psychiatry. Yep, let's say involve psychiatry as well.
That's a good question. I will say, if I'm dealing with something that is, in some ways called organically caused, at least not at the beginning, I will think in psychiatry. I will hope to treat first the cause of this probable symptomatology, and then see if she persists, perhaps thinking in additional causes. But at the beginning, I will not consider psychiatry.
Okay, that's one, and that's wonderfully rich. So psychiatry has signed up. So now you have this team, and you are basically proposed with this decision of starting a treatment. How likely, what treatment do you like this?
So yeah, if I'm thinking a medication to start, steroids definitely will be at the top of my list. I think that if she already has the positive autoimmune markers, ANA, double-stranded, DNA, then if she also fulfills several certain clinical criteria, also we can consider this lupus and then treat accordingly to a lupus flare. So yeah, I think she fits the pattern, at least to my mind, and I will start definitely steroids. The dosing of that steroids, I will say high, but I don't know the number exactly. And yeah, that's my thought so far.
Good. So you want to treat her for lupus, and you want to start at SMB with very high steroids, and probably an immunosuppressant control. Because just steroids won't do the trick for you.
Yeah, so methylprednisolone, yes. High dose IB MP is the best way to start that,
So yeah, so you as a teen, you decide to get IV methylprednisolone and a dose of 1,000 milligrams given daily for 5 days. And the renal team was very actively and very closely involved with you. And they wanted to go ahead and do a renal biopsy to stage to be history stage will prescribe so that they can take a informative treatment. But the patient and family quickly refused the renal biopsy because there had been pros and cons, sign off, and they did not want renal biopsy. Now, nevertheless, we had to get some systematic immunotherapy. So she was also started on oral mycosylamofridine. It's an immunosuppressant, which is very, very protective in lupus patients, lupus nephropathy patients. And also anticoagulation and antiplatelet therapy was started to prevent thrombosis. Lupus patients have increased propensity to develop thrombosis, deep vein thrombosis, sometimes even strokes. So that was.
So there's a couple of things. Really, really challenging case so far. When we think about like a neuropsychiatric onset of lupus, and this is a patient who had no history of autoimmune diseases that we know of. Is that correct? Definitely some unusual characteristics here, right? When the CSF panel, sometimes with the systemic autoimmune encephalitis, you can have a relatively unremarkable looking CSF profile. Like you maybe can have like a mild increase in the white blood cells, sometimes very low, like still like 10 to 15, enough to be abnormal, but not enough to point you in the direction of an infection. It's very unusual for the protein to be normal also. So I thought that was the thing that was the most surprising to me, because usually with most encephalitides, you're going to at least see some abnormalities in the CSF profile. And a new onset neuropsychiatric lupus, kind of as the presenting symptoms, is very, in and of itself, very remarkable, especially in someone in her age group. Usually we're going to be looking at more young adults as opposed to someone squarely in middle age in their 50s. So definitely some atypical presentations in this presentation of an atypical entity.
So this was the case. This was the interesting part, because I remember, Carlos, in the initial history, I told you that she had initially presented to another hospital with fatigue, joint pains, and fatigue, joint pains, and more tiredness. And she was just given steroids, analgesics, and discharged. So I think that was the onset where she actually developed these lupus-like symptoms. That was about 9-10 months ago. And now she developed into this, now she developed into these full-blown neuropsychiatric manifestations, which you want. Yes, exactly.
Yes.
And if you see her blood work, her hemoglobin's 91, I believe, which is low for any age group. So she always had that typical lupus-like symptoms history. Her blood work was not known from there, but if you see her hemoglobin was always low, and so were her platelets. So she, for all you know, she may have this anemia and thrombocytopenia in addition to these lupus classic symptoms which she was having the last 10-11 months. We just saw it right now because it's full blown into this neuropsychiatric component.
That's very important.
Yeah. It is one of those things we do see fairly often in neurology, where someone may have an underlying neurologic autoimmune condition like myasthenia gravis or something, and they got this little short course of steroids and they got better for a period of time. It is right. This kind of non-specific fatigue can definitely be a red herring sometimes, but sometimes it's also the missing link in the story. I also thought the spinal fluid being normal was very surprising as well. With a lot of autoimmune encephalitis presentations, you'll at least have maybe a mild increase in the white blood cells, or at the very least, some elevated protein. So I thought that was also very unusual. The MRI being normal, unfortunately, not as uncommon in these cases. So very challenging when you don't have anything specifically in the neuro realm that tests positive per se. But good point, going back to kind of like the serum biomarkers, and a good example of how, you need those follow-up tests when you have a positive ANA.
Mm-hmm. Yeah, definitely. And I will just add that is a common, what you described, like a patient just giving steroids and then going back a year later to a hospital. At least that is common in my experience in Peru, and I think in other low and middle income countries, we don't have an electronic record history. So yeah, going back and asking the patient about possible diagnosis is a very important thing to do.
And, I'll say, even here in the US, where we do have electronic records everywhere, a lot of them don't talk to each other. So it's not necessarily as good in practice as it is on paper per se. So it is one of those things where, you may not have the records also, even from just within my own state. We'll sometimes have people who went to a hospital 40 miles from here. You would think we'd be able to get those records without too much hassle. Not always the case. So unfortunately, I don't think it's restricted to any particular global region. It's pretty a universal experience, I think, for anyone taking care of patients who get their health care in different areas, sadly. But yeah, Divij, what other teaching points do you have for us, or how did this patient do with, or actually before we get to that, the treatment? I know you said, obviously high dose steroids with methylprednisolone, pretty common for a lot of neurologic autoimmune conditions like multiple sclerosis flares and things like that. The mycophenolate. So I think that's a good point to bring up as well, right? Because we can't keep people on steroids necessarily forever without some long-term side effects. But I think for people who aren't as familiar with mycophenolate, it's important to know that the time to where you're going to be getting a therapeutic effect can be very prolonged. Sometimes we're talking 6 to 12 months of being on the medication before it will really hit its stride in terms of its immunosuppressive effect. So a lot of times you're keeping them on some dose of steroids or other immune modulating medication while you're waiting for these other longer term medications like mycophenolate or azathioprine or what have you to kind of be more effective. And I assume that was kind of the long-term plan with this patient. Is that correct?
Oh, yeah, no. So in addition to mycophenolate, and because this patient strictly and the patient part families will do strictly Fujian biopsy, we can't explore more treatment options. So in addition to the high dose steroids that we had to give, we did go ahead with the mycophenolate, and we also started some benzodiazepines for her anxiety, panic attacks, stuff she was having. Good part of this case was her mental status improved dramatically after we started this treatment, including the benzodiazepines. Her creatinine was still flatlining, was still the same, 3.1. It go down to more case once. Her urine wasn't routinely monitored, but we were happy that in terms of her maintenance status, she was much better than before. And this was a very dramatic improvement, let's say 4-5 days or maybe 1 week. So the neuropsychiatry part is temporarily taken care of here, and we were happy with that. In terms of the renal part, obviously it was a long-term plan, and she was destined for a follow-up, 3-monthly follow-up, 6-monthly follow-up, yearly follow-up, how she's doing, how her nephropathy is doing, and that's when she was started on antiplatelets and anticoagulants as well. And we were hoping down the line, if she ever comes back to us in 3-6 months' time and she's fitter, but now she's right now, she may consent for a biopsy, and we may be able to get better treatment, get a picture of how her nephropathy is. But sadly, so there's one part which I did not mention in the case, which I sent to you, was that this patient actually got COVID in the hospital. She did with COVID-19, and she actually succumbed to COVID-19. She went in the ICU, she was really sick. This patient succumbed to COVID-19.
Was this during kind of with the height of the pandemic when this case occurred?
This was actually... so this was in 2022. This was perhaps in toward beginning year.
And that's always a consideration. We have these people in the hospital and we're immunosuppressing them. Was that thought to play a factor in this patient's immune course? With did she have worse lung injury than normal for this particular variant?
Yes, we not sure. This was the time in the third wave had people in there. So it was tough for us to actually decipher whether her immunity got so bad because he put in on high dose steroids and he used essence, or by virtue of her age, which was not that bad, which was okay. She succumbed to COVID, or was it naturally the COVID-19 which was really bad? Each wave was exceedingly bad, and she got so sick. And she was unlucky. She had to succumb. So these thoughts are mostly born in consideration, and there was a lot of back and forth with the family. Yeah, man. In some case, that's how it goes. It's like maybe we could not say the patient who's might make this a stable means.
Yeah, no, a challenging situation in a lot of fronts, both the diagnostic and the treatment side, unfortunately. Any final thoughts or teaching points about this particular case that you think that you really took away taking care of this patient, Divij?
Yes, sure. So there are a few taken clinical pearls in which to reach out for this time. First of all, neuropsychiatric purpose, or widely known as NPSLE in literature, is a CV complication or a very documented complication characterized by these neurological and psychiatric manifestations in the CV. Interestingly, these manifestations can also occur, they can precede diagnosis initially, they can occur simultaneously and especially diagnosed, or even months and years after SNE was diagnosed. Okay. The second interesting point was that the diagnosis of neuropsychiatric lupus is indeed challenging, even for skilled physicians, even from neurology, nephrology, rheumatology. First, there is no set diagnostic criteria for NPSL, and you may have this diagnosis even in the setting of normally serum and CSF biomarkers, non-immunological imaging, and others as well. So it most likely comes in that realm of a diagnosis of exclusion. People ruled out in the metabolic, autoimmune, and infectious, and procedures. The third interesting part was there were some mimics when you actually considering all of these extremely rare will be working term neuropsychiatric lupus. One was CNS vasculitis, second was Sjögren's syndrome, basically used children normal, the Sjögren's syndrome. You think of Whipple's disease, especially CNS Whipple. You think of Neuro-Behçet's disease, as Karlos mentioned on autoimmune. So in addition to lupus, Behçet's also comes with these neuropsychiatric manifestations. You would think more flashing encephalopathy, we would work in encephalitis, anti-NMDA encephalitis, which includes the NMDA encephalitis, CNS lymphoma, and lastly, in India, disseminated tuberculosis, don't give a name. These were interesting the mix which we thought of when we were working up this case. And last but not the least, the treatment minority neuropsychiatric in this I mentioned is very multi-guided. So these were a few interesting pros and interesting points which I actually known for these keys.
No, that sums it up really well. And that was a great rundown of the differential diagnosis in these types of cases with this kind of subacute onset of neuropsychiatric symptoms. It's definitely one of those things where it's you're definitely looking after all of the strange things that are on the neurologic differential diagnoses.
Yes, all of these three.
I've worked up a number of these cases over the years myself, and it is always a challenge. They didn't necessarily end up being, I think only one of them was neuropsychiatric lupus, but sometimes you end up with the CNS vasculitis or the Neuro-Behçet's or, on and on, right? A CNS lymphoma, fluential. Unfortunately, I've come across that several times as well. And it's one of those things, as one of my attendings would say to me, right? If you don't know it, you can't diagnose it. So I think that's a great list of things to consider in these types of situations. And there's, right, with those folks cranking out new antibodies, you can always throw paraneoplastic syndromes on there as well. But yeah, it becomes a real laundry list sometimes. So it's great to have a framework to pare these down somewhat. Karlos, I'll throw it over to you. Any points of this case that really struck you or that you're going to be taking forward with you in your future practice?
Oh yeah, definitely. So the first thing, always getting a good history is very helpful. So definitely going over the past medical history regarding past diagnosis is very helpful. I will say that even though we had somewhat confusing findings in this patient regarding the MRI and the CSF, thinking about the most clinically logical explanation for this is also important, particularly to not ruling out a disease or ruling out lupus that in this case was the diagnosis, right?
Mm-hmm. Yeah, and this, even if we, right, because the other thing is that, and I think you pointed this out earlier, Divij, is that we're fortunate in this case that we got those serum biomarkers positive. It is not, unfortunately, uncommon to have those come back normal or kind of in the intermediate zone. And right, there's this old adage on the neurology service, somewhat tongue-in-cheek, that no one dies on the neurology service without a course of steroids, right? So that's why I was like, could it be autoimmune? That's always the question mark there, right? So if we don't know what it is, we ruled out infection, we think it could be autoimmune just based on the timeline, the presentation, things like that. Sometimes you do kind of a diagnostic / therapeutic trial of steroids or plasma exchange or IVIG, kind of these first line autoimmune types of treatments. And do we feel great when we're kind of treating blindly and we have a suspicion? No. But sometimes you have to say, like, well, the patient's getting worse, and this is a potential diagnosis that has a potential treatment. So it can be very challenging because, like for instance, let's say it was like neuropachettes, right? And the person doesn't have any aphthous ulcers in their mouth or their genitals. Well, you may not have anything, any markers at all to go off of. And so you wind up with some of these challenging situations where you're like, I think it's this. Maybe you don't have that neuroimmunologist to call in to back you up or things like that. And so you do have to kind of make a decision. And they're very challenging cases almost universally, as demonstrated in this case. So thank you both for your participation today. And any final things that you want to plug or resources that you found useful either in presenting this case or what have you?
No. Thing on if the coaching resource for me has always been the American Academy of Neurology Journal. There are a few interesting presentations over there on the psychiatric news. And it's just this one resource which I found. Second is the Practical Neurology podcast, which is the British podcast, which I do actively follow. And I did a course in neuropsychiatric, not neuropsychiatric lupus, but was in consideration of the diagnosis with the hematoma, United States and the teams which are found. Neuropsychiatric lupus also does fit in this whole diagnostic twin, which affects the symptoms. So for me, for neurology and for when am I right, when am I wrong, and this is what whenever I speak about any cases or write about any cases, these two are the go-to resources for me. In June and the mentally teaching website in June.
Excellent. I love the Practical Neurology podcast is a favorite of mine also.
Oh, yes. I will add, looking at Continuum is also one of the things that do help me a lot. I think they have also an autoimmune neurology edition that is
jumped them out earlier this year. Yes, as someone who works with Continuum as part of one of my other hats, yes, I am of course an advocate for everyone to read Continuum, and for folks who are in middle or lower income countries, there usually is some plans out there that can help you get an issue in your hands as well if you reach out through sometimes the national medical societies. Depends on which country you're in and so forth, but there are different ways, and you can always reach out to the Continuum directly, depending on where you are located geographically, because it can be a little costly depending on where you're living. All right, gentlemen, thank you both very much, and hopefully we'll get again together and do another one of these really soon. If you want to obviously subscribe to the podcast, give us 5 stars. You can find more of our information at theneurotransmitters.com, and you can find our Twitter /X feed at neuro_podcast. All right. Thanks again, everybody. Appreciate you all listening.